Yes, sir. Good morning, everyone. Sir, can you hear me, sir?
Yeah.
Okay. A 10 months female child in Lean Kaise, hailing from Bangladesh, informant being the mother with reliable history, presented with complaints of recurrent respiratory tract infection since birth. Child was diagnosed to have congenital heart disease at birth. Since then, child has history of 4 episodes of respiratory tract infections, which required antibiotics, with the last episode being 1 month back. The history of feeding difficulties, history of forehead sweating while feeding, history of sucrose cycle, and history of failure to thrive. No history of cyanosis. Birth history, it's a preterm baby 1 month before the expected delivery date. Cesarean section with birth weight of 1.8 kg and with NICU admission for 11 days, but not on the ventilator. Diet history, baby was exclusively breastfed till 5 months of age and then started on veg diet since then. Immunized up to the age. Developmental history is there is gross motor developmental delay. Baby does not crawl or sit on its own, and the other fine motor and verbal development are normal. Family history, baby is the first child. No other family members have a significant family related illness. And baby is on lacilactone and digoxin for the past 5 months.
Okay, hold on.
Yes.
Go back to your history. A 10-month-old child with
Yes, sir.
is unusual to have recurrent respiratory infection. Recurrent respiratory infection comes in a little older child. A 10-month-old child is confined to the house, and that is rare unless it is a very large left to right shunt. Okay.
Yes. Yes.
So this child has become symptomatic before the age of 1 year. So at the age of 10 months. So there is recurrent respiratory infection. There is forehead sweating, and there is sucrose cycle and failure to thrive. What does it tell you?
It suggests the increase the left to right shunt, increase pulmonary blood circulation, and LV failure.
The child is already in failure,
Failure. Yes, sir.
heart failure already. Okay.
Yes, sir.
Now, you said she was delivered by LSCS. What was you should go a little bit more detail, especially in a child like this. You have to know what is the indication for LSCS, whether there was any fetal distress, whether there was an abnormal lie, or what were the other problems. And then also the APGAR score at birth. They may not know, but at least you should inquire. Some people may know. So, okay, that will give you a clue whether there was a problem right at birth. And you said that the child was diagnosed to have a CHD at birth,
Yes,
right?
sir. Yes, sir.
So by history, this patient seems to have a left to right shunt in cardiac failure at the age of 10 months.
Yes, sir.
All right.
Yes, sir.
So what are the possibilities that come to your mind?
One is a large VSDs can present
Yes,
like this, and
yes,
large PDAs.
large PDA, VSD and PDA. Why not ASD?
The ASD will take some more time. The shunt will be even more. It will take more time to present.
ASD is between two low pressure chambers, so it will take much longer for it to manifest. Okay, generally ASD does not present failure in this age group. Okay, so
Yes,
you
sir.
have ruled out ASD. You have got VSD and PDA. VSD may be associated with other abnormalities that you will have to see how with your physical examination and your investigation. So this is how you'll break up this history, right?
Yes, sir. Yes, sir.
Okay.
What's the usual age when the symptoms start in these cases?
The large PDA symptoms starts before 1 year, sir.
That's not a good
No,
answer.
understand his question.
That's not a good answer.
Understand his question. What is the usual age? What happens immediately after birth? What is the PVR at that time? And when does the left to right shunt increase?
After 6 to 8 weeks late, PVR starts decreasing immediately after birth, but after 6 to 8 weeks, it presents.
Yes.
Yeah.
So once the PVR goes down, and then only the left to right shunt gets manifest.
Yes.
Unless, as you said, a very large PDA or a very large VSD can present at birth.
Yes.
Okay.
Yes.
So you must understand what the examiner is asking you. All right. You have to have some amount of anticipation.
A few things, other things that the examiner expects to know. What a normal time of closure of PDA. What is it that keeps it open? What is the cause of closure of PDA? What happens soon after birth? What is it?
The physiological closure starts 12 to 18 hours after birth, and the anatomical closure starts after 3 weeks. And low oxygen level and prostaglandins keep the PDA open.
The physiological closure comes up to 15 hours. The other is 2 to 3 weeks it closes. And what's the cause of the closure of PDA?
In term influence, it's increasing oxygen tension and reducing the clearance of prostaglandins with fall of pulmonary vascular resistance, closes the PDAs.
What's the cause of in utero? What keeps the PDA open?
Because I didn't get you.
Mainly the prostaglandins secreted by the placenta. So as soon as the child is born, separated from the placenta, it's got a blood close. And the oxygen, the child starts breathing the oxygen saturation, the PDA closes. Normally, unless it's a very large PDA, the symptom starts only at 2 to 3 months, And the main symptoms, because of the large left to right shunt, is a large volume overload of the left side. The left atrium, the left ventricle especially, left ventricle and diastolic pressure goes up, and they go into left heart failure. So don't say forehead sweating, that's not important. Classically, you should say feeding difficulties. Feeding difficulties is what is suck rest. So the correct name, don't say suck rest, that's this symptom actually, the feeding difficulty is failure to thrive, repeated respiratory infection. Then they all examiners ask you, what exactly do you mean by frequent respiratory infection? Means it lower tract respiratory infection. The URI, the children get so often, And what are the causes? That thing we have explained to you many times. You should be thorough with that. Okay.
Yes. Yes.
Sweating. Forehead sweating.
So in effect, what keeps the ductus open, and what are the conditions where it has to be open for survival? That means ductus dependent circulations.
The ductal dependent systemic circulations are like hypoplastic left heart syndromes, interrupted aortic arch, coaptation, or congenital critical long aortic stenosis, and duct dependent pulmonary circulations are critical.
Coaptation. It's a pre-ductal coaptation.
Okay.
Because pre-ductal coaptation, the descending aorta is continuous with the PDA, So that's a.
Okay. And duct dependent pulmonary.
Yeah.
Okay. Duct dependent pulmonary circulations are critical pulmonary stenosis, TOF with pulmonary atresia, or single ventricle with pulmonary atresia, CGA intact ventricular septums.
Where there is decreased pulmonary blood flow, where there is severe RVOT obstruction, then you need the ductus to keep the pulmonary circulation going.
Yes.
Okay. So you should be able to tell these things. Supposing that this was just a PDA, all right?
Yes.
So you said physiological closure within 48 hours and anatomical closure in 3 to 4 weeks.
Yes.
If you want to help closure, what will you do?
So you can give COX inhibitors like indomethacin or ibuprofen we can give to close the
Yeah.
PDS.
Do you know the dose?
Yes, sir. 0.2 mg per kg. 3 doses with 12-hour interval, sir.
How much?
If required, we can do
What's the dose?
0.2 mg per kg, sir.
Yeah.
The thing is
Required, we
that
can repeat another dose, sir.
the indomethacin, what is the alternate?
Ibuprofen, sir. 10 mg per kg. 10
It's
mg.
used only in preterm babies, you know. In a normally full-term baby, the PDA cannot be closed by drugs, you know. It's only in preterm babies that you.
Yes.
And you should know something about what's the incidence of PDA.
Incidence of
And
PDA is 5 to 10%
You
in
got that.
excluding preterm birth.
Good. Okay. What is
Excluding
natural
preterm.
history?
The natural history, the physiological closure happens at 12 to 15 hours after birth and anatomical closure after 3 months. And PDA is unlikely to close after 6 months of age.
Usually by 3 months they close. Unlike you say VSD or ASD, no, it's different. And very large PDAs never close also.
What is the what is the expansion of PDA?
Patent ductus arteriosus.
No, I think the terminology was changed some years ago. It is called persistent ductus arteriosus. Okay.
Yes, sir.
Okay. Yeah.
Okay, what's your examination finding?
General examination, child is conscious, alert, no pale or repressed cyanosis or lymphadenopathy. There is a cleft palate and left preauricular tag present. Vitals, heart rate of 118 per minute regular, BP of 96 by 56 millimeter mercury, within right upper limb in supine position, saturation of 99% in the room air with a respiratory rate of 30 per minute and temperature of 98.6 Fahrenheit. Length 69 centimeter, weight 6.5 kg with BSA of 0.35, which is underweight for the child.
Should have said first because one of the main symptoms is tachypnea. This is
Yes, sir.
34 minutes. Yeah? So the initial symptoms itself, then tachypnea is one of the main manifestations and tachycardia also because of heart failure. All the symptoms we said about the failure, the feeling difficult failures are due to left ventricular failure. Okay, left atrial and left ventricular volume overload and failure. That never occurs in ASD. That can
Yes.
occur in VSD only. Left ventricular failure never occurs in an ASD.
You mentioned cleft palate and preauricular tag. Does that conform to any known syndromes? And what are the syndromes common in PDA?
Maternal rubella syndromes and trisomy 21 and 18, and there is one more syndrome, CHAR syndrome, CHAR. These are all syndromes associated with PDS.
Is this left preauricular tag a part of any of those?
No, sir, I didn't check this.
I don't know if it is part of trisomy 21, but I don't know. Okay. All right. Go ahead. So you must know some classical syndromes associated with congenital heart disease and look for them in your general examination when you get a small child. Normally, I don't think you will get a small child less than 1 year in your exam. But if there are no other cases and if you do get them, so you must have some amount of idea of the various syndromes that are associated with congenital heart disease. Okay, make a
Yes,
list
sir.
of them and then keep a ready reckoner so that you can revise it more often.
Yes. Systemic examination. On inspection, apical impulse, there's a hyperactive precordium. Apical impulse seen half inch lateral to the midclavicular line. No scars or chest deformity. Palpation, apical impulse felt in the left 6 intercostal space, 1 centimeter lateral to the midclavicular line, which is hyperdynamic in nature with palpable P2. There is no parasternal heave or no thrill.
No thrill?
No, sir, I couldn't able to appreciate that.
Wow. That's unusual. Okay.
On auscultation, S1 normal and loud S2 with continuous machinery murmur heard over the left infraclavicular and upper left sternal border conducting to the back. And there was additional mid-diastolic murmur burst heard in the apex in the left 6 intercostal space.
Why do you get continuous murmur? And what do you mean by machinery murmur?
The continuous murmur because the shunt occurs in both phases of the cardiac cycle.
Okay. And how do you differentiate this continuous murmur from other systolic diastolic murmur?
Usually there will be S2 we can able to heard and here we can able to, there is a gap between the murmurs and the two separate heart sounds. Here it will be a continuous with the peak at around the S2.
Yeah, it spills over the sound S2 and goes on to diastole. That is why it is called continuous machinery murmur. And what happens when there is severe pH?
When happens severe pH, the diastolic component reduce only will have only say systolic murmur. So only a systolic murmur or murmur will disappear.
Okay. You said mid-diastolic murmur heard in the apex. What murmur is this? And what is the significance?
I think it's increased flow across the mitral valve, I think, because the relative mitral stenosis, increased flow murmur.
What does it signify? Flow murmur across the mitral valve in a left to right shunt. What does that signify?
Left out volume overload.
No. One, it is a post tricuspid shunt. Second, the pulmonary flow is 2:1 from the systemic flow. So it is twice the amount of this thing. So the shunt is more than 2:1. Then you'll get a flow murmur across the mitral valve in a post tricuspid left to right shunt. You follow?
Yes, sir.
Similarly, this can happen in VSD as well. But if similarly, you will get a post mid-diastolic murmur across the tricuspid valve in a ASD with more than 2:1 shunt.
Yes.
So that is the significance of this diastolic murmur. Here you said you could hear it well and good, but in a case if you don't hear it, you must mention the negative part of that, so that you know clinically also that this left to right shunt is not more than 2:1.
Yes, sir.
And what is the significance of this 2:1 for you as a surgeon?
Yeah, we can intervention is needed, sir. Operable case.
It requires surgical correction or maybe any intervention. All right. Okay. How do you decide?
You can.
Sorry, sir. Go ahead.
After whose name is this murmur known?
Gibson
man. You know what exactly the definition of a continuous murmur? You said in a way, it starts in systole, it crosses the second sound, goes to diastole to varying length. So it marks the second sound goes with. And in the diastole, it may be varying. And the other thing is that, so what about the severe aortic stenosis with AR? That murmur, can it come as a continuous murmur?
So the AR is a to and fro murmur. Basically, AR is a to and fro murmur.
It's a to and fro murmur because usually in all continuous murmurs, the flow in systole and diastole are in one direction. It starts in systole, crosses second sound, goes to diastole, and it's always in one direction. That's why, which are the most common continuous murmurs you get?
Collaterals in coaptation.
Huh?
What?
Collaterals, sir, doing collaterals murmur.
That may be
that is a very rare cause, man. Come on, commoner things first. You get
AV
PDA.
fistulas.
What is the differential diagnosis of PDA?
PDA.
The VSD with AR, AV fistulas.
VSD-AR is not a continuous murmur.
It's not a continuous murmur because I said it should be in one direction.
Yes.
In
VSD-AR is not continuous. So
continuous.
what is the commonest differential diagnosis for a PDA, which is very commonly missed? It's an aortopulmonary window.
Yes.
AP window is the next important differential diagnosis for a PDA. Rarely you will get coronary cameral fistulas.
Yes.
Yeah.
Yes, sir.
And
So,
rupture
and co-op with collaterals is seen only in a very late stage in an adult, and which many people don't even get it. It's a very, very rare cause of continuous murmur in the heard in the back.
Yes, sir.
in
Don't
sequence.
bring that in. Don't bring that in this age group.
You should
Yes,
say
sir.
PGA, you say coronary arteriovenous fistula, coronary cameral fistula, then the rupture sinus valva, then peripheral pulmonary stenosis. Because in peripheral pulmonary stenosis, it depends on the distance where the peripheral pulmonary stenosis. So it goes beyond systole, it goes to diastole. So that also comes in the rare type of continuous murmurs. There are about 8 or 9 of them who are cause of continuous. We should know 1, 2, 3 like that. And
Yes, sir.
10-month-old child with AP window usually may have continuous. But if the child is 2, 3, or 4, usually, as Krishna said, the PDA also very large later on, the diastolic component disappears. Similarly, in a large AP window, the severe pulmonary hypertension occurs early in life, rather more than the ductus, so the continuous murmur usually disappears by the time they are 3 or 4 years old. Okay.
And when the examiner asks you a question, what are the causes of continuous murmur? You must talk or tell the conditions with reference to the case that you have at hand. Okay.
Yes,
This is a 10-month-old child. Don't talk about coarctation with collaterals. Don't talk about something else. This thing. So PDA, AP window, even RSOV is rare because RSOV occurs even if there is a sinus of Valsalva aneurysm. The RSOV occurs only with physical activity, sudden intense physical activity when there is rupture of the sinus. So RSOV is not all common in a 10-year or 10-month-old child. Okay.
Yes, sir.
So just don't quote something from a book. You have a patient in front of you. You must have a differential diagnosis, rule out certain things, and then come to a decision of what you're going to do with this child. That is what the examiner expects of you.
Yes, sir.
Okay, go ahead.
Other systems, respiratory system, normal vesicular breath sounds, no added sounds, and bilateral equivalently. Abdomen now organomically. CNS, there is gross motor developmental delay. No other neurological deficits noted.
Speak little slowly, and because the examiners are old, so they appreciate. Always speak slowly and clearly, So.
Okay.
So
diagnosis: acyanotic congenital heart disease with post-tricuspid and large patent ductus arteriosus, persistent ductus arteriosus, in failure with severe pulmonary hypertension, in sinus rhythm, no infective endocarditis.
Okay. What are the indications? What do you want to do now?
You should also add on anti-failure treatment. Okay.
Okay, sir. I would like to investigate further to confirm my diagnosis. and plan for the further management, sir.
Hmm.
Chest X-ray. The AP view chest X-ray is well exposed, slightly rotated to the right with CT ratio of 0.6 and with mediastinal widening, would suggest could be a thymus shadow. With PA bale looking full with plethoric lung.
Measure 0.6 because it looks bigger than 0.6 anyway.
Okay.
Yes, sir. With plethoric lung fields. ECG, sir. A standardized ECG showing heart rate of 19 sinus rhythm. I look for the signs of volume overload. There is QH in the V6, sir, which is clearly not appreciated here. But there is QH only in the lead V6. Apart from that, no other positive findings in the system.
What is the what are the okay? Is this ECG corroborating with your diagnosis?
Not much, sir. Only the QH in V6. Apart from that, not much.
Okay, tell me one single view in echocardiography which will diagnose PDA. What is the view that you look for? What is the view that you'll see? I mean, look for in a case of PDA on echo.
Sorry, sir. Don't.
Supraclavicular or suprasternal view.
Okay.
You put the probe there, then you look for the PDA. Okay?
Okay. Okay.
So the
Right.
examiner expects you to say the suprasternal view and number 2, high up on the left parasternal view. The two views, mainly the suprasternal view and the high left parasternal view can show
Okay.
the PDA. Even in coarctation, it's like that. To see the coarctation cell, you have to do such a view. Okay.
If you don't do this, you will miss the PDA. And many a time the PDA is missed on the table. I mean, missed on this thing, and you'll find it as a surprise on the table.
Yes, sir.
Both AP window and PDA are very often missed on echo. Okay. So what is the echo?
So levocardia showing a large PDA of 11 mm with left to right shunt with peak gradient of 46 mm mercury with left arch and confident branch PS, RPF 10 mm and LPF 10 mm. Sir. With interventricular septum and interventricular septums are normal. Interventricular septum is normal with the PFO of with left to right shunt, dilated LA and LV with severe PAH and good biventricular function. And there is increased pulmonary venous return which is noted in the mitral valves.
What is LA and what is the aorta size?
They have not mentioned about the size, only they mentioned it is dilated. Size they have not mentioned.
Today homework, go and read about LA iota ratio and what is the significance of that.
It should be more than 1. If it is more than 1.5 to 1, it is significant.
What does it signify?
That's a significant. Large shunt.
What is the size of the PDA in this?
11 mm, sir.
Huh?
11 mm, sir. 11 mm.
Okay. What else you want to do? Is there any other abnormality?
No, sir. Only PFO. No other abnormality.
Abnormality? No, no other abnormality.
No other abnormality.
So what do you want to do in this patient?
So can we do CTs necessaries for these patients, sir? To
What
look for any
additional information are you wanting to know in a CT?
to look for the aortic pathology, anything. Sometimes after PDA ligation, coac might manifest.
If you have a right aortic arch, where will the PDA be?
Close the innominate,
No.
the base
sir.
of innominate.
No, sir. Please go back and read, sir.
Okay.
PDA does not change its position. Okay. It's not a mirror image thing.
Okay.
Go back and read about the anatomy in a right aortic arch. All right.
Yes, sir.
Yeah. So these are questions that the examiner usually, these are trick questions which are asked to differentiate or to decipher whether you are a good student or an average student. All right.
Yes.
Now, what else you want to do? You want to do a cath on this patient?
No, sir. There's in clinical, there's the signal is like high shunt showing that QP is more than 2:1 on clinical findings suggestive. So they won't need cath, sir.
When will you not operate a PDA? When will you do more harm if you close that PDA? So for that, you must know the pulmonary vascular resistance.
Yes, sir.
Okay, what are the cutoff levels?
Less than 6 to 8 wood units we can operate. More than 8 we won't operate. Sir.
No, that is
more
for
than 10 we won't operate. 8 to 10 we have to know the oxygen testings.
5 or 7 for an ASD, 10 for a VSD, 15 for a PDA. That is the cutoff limits for a PVR. Okay. So you must remember these values all the time. You have ASD, VSD, and PDA. These are the commonest shunts that you see, left to right shunts.
Okay.
So if the PVR is more than 15, then the patient is likely to go into Eisenmenger, and it's detrimental to close the PDA. What are the different types of closure of PDA? You know, and when will you choose what?
One is simple ligation, another is the double ligation with excision, sir. In case of large PDAs,
Excision.
Don't
you excise the PDA?
Division, sir. Ligate and division, sir.
Not ligation. Ligation and division is not there. Ligation and transfixation. Suture and divide. If you have to divide, you have to close both ends with a suture, not ligated, because the ligature will slip, and then you have disaster on the table.
Yes.
Okay.
Yes.
So triple ligation with ligation on either side with a transfixing suture, division and suture, then suture and division rather. Then what are the later things?
Later is clips.
Clips.
Yes, sir.
Clips, yeah, clips in a preterm, in case preterm child, you can do a clipping of the PDA in the ICU. Yes, fine, that's agreed. What else? Arey, your cardiologist will not send you a PDA, man. Amplatzer device to close the PDA.
The device closer, yes, sir.
Yeah. So what are the contraindications for device closure of a PDA?
Weight less than 6 kg and less than 6 months of age. very large PDAs, more than 10 mm, sir. 10 to 14 mm.
Right.
Size I'm not so sure. More than large PDA.
1.5, 1.5 centimeter. Before you come to those things, I never said this patient you are going to do a CT scan. That's unnecessary investigation. In a complex congenital heart disease, you will do it. But in a PDA, you never do a CT scan. It's not required. It's unnecessary investigation. Number two, previous time we used to do catheterization, diagnose PDA, and to differentiate and AP window. Do you know the catheter position? But nowadays we don't do between a PDA and a ductus and a AP window. When it passes right heart catheter, how do you diagnose it's a PDA and not an AP window? What's that typical catheter position in a ductus called? You know? The right heart catheter goes to the right atrium, right ventricle, the PDA, the pulmonary artery PDA, then comes to a descending aorta. It gives a classical theta position or a reverse 8 position, theta position. Whereas in AP window, it goes up into the ascending aorta, So the position, from the position of the catheter itself, in olden times, when we used to do catheterization for such cases, to differentiate between AP window and PDA.
So the examiner many a time will ask you to draw the course of the catheter in a PDA.
Okay, sir.
Okay, you must learn that. If Prasanna Sinha comes to you as an examiner, he will ask you the catheter course in all the congenital hearts. So it goes through RA-RV, PA, across the PDA, turns round, and then goes down into the descending aorta, and it should cross the diaphragm. You remember that. It should cross the diaphragm into the descending aorta. So I think it is called a lambda sign and not theta.
Yeah. But looks like a reverse 8 actually.
Yeah, because these are all Greek letters, so we are not familiar with that. So that is the course of the catheter, right? And then you have to, what are the components of a cardiac cath? Many a time, without injecting a contrast, you can know the diagnosis by the course of the catheter. Then you have pressure studies. Then you have oximetry. And then you give an angiogram in inject a dye and do an angiogram. These are all the various components of a cardiac catheterization. Okay.
Okay, sir.
So as sir said, it is not required in an isolated PDA. I mean, cardiac cath is not, CT is not required. Sometimes if you have a doubt whether this patient is operable, you can do a cardiac cath, and with oxygen, you can look for reversibility of the shunt, and then also measure the PVR. With all these information, then you will know whether you can operate on this patient. What is the approach? So this patient, okay, sorry, this patient is not suitable for device closure because it's a 10-month-old child with a failure to thrive, and there's a large PDA. So if you have to put a more than 10 mm amplifier device, then it may cause obstruction both to the PA and the aorta at that age. Okay.
Yes.
So the two contraindications is a large PDA and a low weight child.
Yes.
Why is that significant? because your femoral artery and femoral this
Yeah,
thing
both.
will be much smaller, right?
Yes.
So vascular injury is much more common in a smaller child. So that is why there should be some minimum growth for you to do a catheterization device closure.
Okay.
So this patient requires surgery. This patient requires surgical closure. So how will you do?
Left postlateral thoracotomy to third intercostal space, third or fourth intercostal space.
Okay, third or fourth. All right. Okay. And what you do? What is the first step?
Right lateral decubitus position, controlled hypotensive anesthesia.
Yeah, you have done a thoracotomy. How are you going to position again? You've done a thoracotomy. What else do you do? What do you do?
Sir, retract the lungs anteriorly, sir.
Okay.
And
Anteriorly and interiorly. How do you do that?
Anteriorly. Sir, by with a wet sponge.
Yeah.
Can push.
Because you have a single lumen tube. So you don't generally use a double lumen tube for these patients. So you will put a wet sponge and push the lung down. Then what do you see?
So the mediastinal pleura will dissect, open the mediastinal pleura.
There is some important structure just before opening the mediastinal pleura.
Intercostal veins. Intercostal.
Yeah, intercostal vein. The supreme intercostal vein cuts across that area. You have to ligate and divide that supreme intercostal vein and then open the mediastinal pleura. Okay.
Yes.
You open the mediastinal pleura right up to the origin of the left subclavian vein, artery on the top and below for 2 to 3 vertebra below.
Yes.
Okay. Then what is the next step?
Identifying the PDAs.
How do you identify the PDA?
So the recurrent laryngeal nerve might be close to the PDA.
Yeah. First, you will palpate. You will palpate with your finger. There will be a thrill.
Yes.
Right?
Yes.
And then you have to identify the recurrent nerve. Yes. Before dissecting the PDA, you have to do something else. We were taught that the present day surgeons don't do it often, I think, because they are all bold surgeons. But when we were taught, we were always taught to do a particular step before trying to dissect the PDA. You always loop the aorta above and below.
Yes, sir.
Okay, so that you can retract it a little laterally and identify the PDA. PDA is a very thin structure, very delicate structure. You have to be very, very careful. It is thinner than the pulmonary artery. Pulmonary artery is the most delicate structure within the chest.
Yes.
And PDA is even more delicate. So you have to be very, very careful.
Yes, sir.
Okay, then you isolate the PDA. Then what do you do? Depending on the size, you will decide whether you are going to triple ligate.
Yes.
Ligate on both sides and then close the in and put a transfixion suture in between, or you will divide and suture.
Yes.
Clamp, divide, and then suture both sides.
Yes.
Yeah.
Yes, sir.
So when you're going to be ligating, a practical question, which side will you ligate first?
Aortic side, you should ligate first, sir.
Yes. Aortic side, you have to ligate at the aortic side first. At the same time, you have to tell your anesthetist to drop the pressure so that the aorta becomes softer, a little softer, and then you can tie that.
Yes.
And then go on to the pulmonary artery. Don't forget this step.
Yes, sir.
This is for everybody, whoever is listening. The aortic side is always ligated first, and then the coronary artery side, and then you can transfix it. Okay. Now, what are the conditions where you have to divide and suture, and you cannot do a triple ligation? Do you know there are 5 conditions where you have to divide and suture? No, I don't know. If there is a short ductus, if there is a wide ductus, if there is a hypertensive ductus, if there is a calcified ductus, or if there is an aneurysmal ductus. These are the 5 conditions where you have to divide and suture. You cannot ligate. Understand? Hello? No
Yes, sir. Yes,
response.
sir. Yes, sir.
So these are the 5 conditions where you necessarily have to divide and suture.
Okay.
How do you divide and suture? Or rather clamp, divide, and then suture. And what suture do you use? Have you seen a division suture done?
No, sir. Division suture.
Hurry, 5th year man, come on, yeah. Please don't say this in the exam. Find out how it is done.
Yes, sir.
Yeah, if you have not seen one, there are places. Talk to your consultants, see how it is done. What are the steps?
Okay.
Division and suture is an important method of suturing. Closing a ductus. In the olden days, we used to do triple ligation, and few RBCs go along across the PDA, and then the cardiologist would say, "Oh, there is a residual shunt, residual shunt." Nowadays, they put in a device, and there will be torrential flow through. They'll say, "Oh, it's okay, no problem. It will close in 6 months' time." So the bar is changed. The high jump bar is changed accordingly. You follow? Just like closed mitral and balloon valvotomy. So division suture and triple ligation. What are the other methods? Supposing you discover a PDA on the table which was not diagnosed pre-op, then what do you do? How do you manage that?
We like it before going on pumps. And
Yeah.
little.
You have to decide, you dissect it and then loop it before going on pump. And just before going on pump, you will ligate it and then go on pump. Why? Why? Why this?
If
You
we
must
go
know
on,
why.
if you go on pump, there will be a huge flow into the left side of the circulation. You get distant.
Left-sided circulation?
Left heart will get LV will get distant.
One, okay. LV. Your operating field will be flooded
Flooded with. Yeah.
because the whole thing will keep coming from the PDA.
Yes, sir.
And one more important thing, your myocardial
Not able to
protection.
maintain the pressure. Yes, sir.
Yeah. The myocardial protection will suffer. There will be increased returns on into the operating field, and then the whole area is flooded. So you have to close it. So what are all the methods to close on pump?
Do the simple ligation with the Kirkland's silver method, like tying the silk sutures.
No,
That
where
we
will
can-
you identify the PDA? How will you dissect for it? Where will you look for it?
Will dissect beyond the PA bifurcation, close to PA bifurcation.
You're on median sternotomy, you open the pericardium.
Yes. I will dissect close to the PA bifurcations. We are close and beyond the PA bifurcation, close to the LPSA. And I will trace it. So it will follow the when it will. I will trace it and it will go into the aorta. The connection will, and then it dissect around it.
Supposing you damage the PDA during that time, what will you do?
Then we have to go on TCA, sir.
Before that, Jairaj sir will tell you CMC method of closure. Christian Medical College closure. What do they do? What did they do? You can pass a Fogarty through the PDA into the descending aorta, distend the balloon, gentle tug on that so that the bleeding stops, and then you will suture ligate the opening.
Yes.
Yes, sir. Is that
Yeah.
right? Is that
Yeah, it's the only original thing described from CMC, but go ahead.
so? You must know how to do that. Okay. So it should be, because these are all emergencies on table. And
Yes.
you should be able to get out of these emergencies. Otherwise, you are in trouble, serious trouble. So these steps you should.
Flooded field can be able to identify the distance, like able to pass
Sorry?
when it is ruptured, it will be full flooded field. Can be able to
Usually, the aortic end will be bleeding.
oh,
When you have a hole in the PDA and then you have made this thing, the aortic end will be bleeding.
okay.
Similarly, when you are doing a ligation, also it can happen.
Yes.
And you don't tie this like this. You have one finger down onto the PDA and then gently tug on the other limb when
Yes,
you are tying and tightening the suture. If you don't pull like this on both sides, then the PDA will be in your hand. So these are things that you have to be very careful. Remember that the PDA is a very delicate, the most delicate structure within the chest.
Yes.
The examiners usually ask you, what are the shapes of the PDA? What are the types of PDA? There are 3, 4, 5, What are normal shapes of the PDA?
Conical window shape.
Conical?
Window shapes.
Before that, conical where? Which end is the apex of the
Aortic is the base. Aortic end is the base.
So that's a classical sign. And the
Yes, sir.
PDA starts closing from the pulmonary side. It's a conical one, a long ductus, a short ductus, a kissing ductus. That means almost like a AP window in the ductus position. That means that's just because it's a kissing ductus, no ductus at all. Tortuous ductus, vertical ductus. There are so many types and shapes of your treatment depends upon. I always used to teach students, in a baby like that, a full post-thoracic thoracotomy is not required. Muscle sparing incision, only the lateral node is cut, and then
Yes.
the lateral thoracotomy. The most important thing is that we describe the incision on the mediastinal pura, ligation superior intercostal vein. Most important thing is that when you try to go around the ductus or anything, It's always done under controlled hypotension that you should insist the anesthetist bring down the systolic pressure to 60 to 70 millimeter. Previously, they used to use halothane, but halothane being very toxic to the heart. Usually nowadays, either nitroprusside or nitroglycerin is used, and always when you dissect down the ductus, you always have a controlled hypotension, then only. Otherwise, when it's tense, when it's tense, likely to break. And the other thing, if it's large ductus, pulmonary hypertensive patients, it's always better under controlled hypotension to pass a tape around the aorta above the ductus, under the arch, and on the descending thoracic aorta below the arch. So, you are in trouble breathing, you have to cross clamp the aorta above and below. Above the ductus, below the ductus. How long you can climb that at normal temperature on a left thoracotomy?
So we can clamp for 20 to 30 minutes, sir.
20, don't say 32. Classically, we stay 20 minutes. So, a safe surgeon operating on a large ductus or a hypertensive ductus will always tape the aorta above and below and pull it onto the lateral side. Then it's easier to dissect under the ductus, to pass a right angle under the ductus. So that should be done always under controlled hypotension. Then it depends on the length. I always taught the students just simple ligation is not a good thing because recanalization may be. So if there's space, double ligation and the transfixion, that's one of triple ligation. You
Yes, sir.
ligate the aortic side first. And very often when you try to tie this, there's a tendency for the suture to slip to the middle of the PG. How can you avoid that? Because you have got a small length, So you want,
Okay.
there are two methods of avoiding it. One is taking a adventitious bite on the aorta, on the aortic analysis, and passing the suture under that and trying that. In that case, it will not slip to the middle. The other is the assistant holds with two forceps the suture toward the aorta and the controlled hypertension, and then suture tie the aortic end and then tie the pulmonary end. And for that, to get more length of the ductus, you always dissect the pericardial lappet, That when you dissect the pericardial lappet medially, that's when you see the recurrent laryngeal nerve. Sometimes when you dissect the pericardial lappet, you make a small hole in the pericardium. Actually, sometimes you can see the pericardial fluid comes out. That doesn't matter. But important thing that you don't injure the phrenic nerve. So then you tie the pulmonary end. In the middle, you take a transfixion suture. When you take a transfixion suture, you know that there's a patency, there's blood coming out, you know that your tie on either side, educate, so you take a transfixion. But larger ductus, it's always better to ligate and suture. Division and suture, that's what's called. That means if it's a long one, you can do two ductus clamps, one on the aortic end, one on the pulmonary end, and divide if there is. If there is enough space. Otherwise, what we have actually from AEM, they have described actually chokers. You use a Cooley clamp, the medial side onto the aorta, having little bit of the aorta and the ductus, and another Cooley clamp on the pulmonary end, so that you get enough length. So that if you put two ductus clamps and you divide and suture, you may not get a good cuff, So in such cases, you can always There's a coolie clamp, the medial side, under the aorta, under the ductus, onto the aorta, and then same clamp on the pulmonary side, and you get more distance. The other thing, Dr. Stanley don't always use to do last blood test, clamp the aorta above the ductus, clamp the aorta below the ductus, and then a straight clamp for the pulmonary end, and then divide and suture the aortic first, and release the aortic clamp so that your time doesn't exceed 20 minutes. Then do the pulmonary end. The other thing, suppose it's ruptured, a lot of bleeding. What can you manage from the left thoracotomy? Krishna, these are all olden times. Nowadays, people don't do that. Then similar thing. That means if you have, as a safe surgeon, pass a tape above and below the ductus, you can clamp the aorta above and below, and you may not get enough space to clamp the pulmonary artery because bleeding is in the pulmonary artery. You can open the pericardium, and then because the ductus actually arises just 3 millimeters after the origin of the left pulmonary artery, you can clamp that. Not the full pulmonary artery, but I put a clamp there. Then you can switch it. That's what you do when you are in trouble from the left thoracotomy. From a median sternotomy, a lot of people. And which condition you always dissect and ligate the ductus in a baby. Median sternotomy. Which condition have to do that? And you must know the steps how to do that. It's always done when you are planning for a circulatory arrest because you want to pinpoint PDA. When circulatory arrest occurs, air embolism can occur into the brain. So in all those cases, whether ductus is diagnosed or not, it's always safer. And that's done by taking stay sutures on the pericardium above and pull it above. And take a small mosquito and take on the small bite on the adventitia on the pulmonary artery and pull it toward the liver. By retracting the pericardium above, you can dissect on top of the pulmonary artery. That's your steps done in such cases. And then you can slowly dissect, and then you can pass around the ductus arteriosus and ligate it. Except ligate it before you go on bypass. Except in kids with tetralogy or something, with PDA is only feeding thing. You tape it, put a ligation, then go on bypass and ligate it. Because the oxygenation difference. The other thing Krishna was describing, the CNC method, is actually reduce the flow, open the main pulmonary artery because you don't want to be caught with your pants down after going on bypass. There's a ductus, you miss, you open, you flood the field. So in such cases, this was described in 1970s. You open the main pulmonary artery, put a Fogarty. If it's slightly bigger, you put a venous Fogarty. Or you put a arterial Fogarty, gently pull it, and then close the ductus from inside. Same thing can be done for a large calcified ductus by going on circulatory arrest and putting a patch, because calcification may be less on the pulmonary side. So these things you should definitely know how to get out of trouble during trouble like a bleeding. Okay.
Another one important Practical tip that I forgot to tell you is before closing the ductus, you must always do a trial clamp or just occlude the ductus with a vascular forceps for 5 minutes. Make sure that the hemodynamics are okay, then only you will close the ductus. So that if you have missed a ductal dependent circulation, then you close the ductus, then you are in trouble. So this is one more practical tip that you should do. Always you should keep it in your mind, and whenever you're trying to tackle the ductus, you have to do that. First, like as I said, tape the aorta above and below, identify the recurrent nerve, safeguard it, trial clamp just put a forceps and then just hold the ductus and see whether the hemodynamics are maintained, and then you can do the other things. So these are important practical tips that you have to have before closing a ductus.
That's also during cardiac catheterization to see whether pulmonary vascular resistance drops or not. There are many methods. One is oxygen. The other is balloon occlusion of the ductus during a cardiac catheterization, and to see whether the pulmonary artery pressure falls if a balloon occlusion is there. That they used to do it. I don't know whether they do it nowadays, but that's a one way of deciding whether the ductus is operable or not.
At what age will you recommend closure of the ductus? Not in this patient, but generally if you see an asymptomatic ductus, at what age will you close? And does it require closure?
Yes. So in case of asymptomatic, sir, in case of asymptomatic.
Yeah. Do you always have to close the duct if you see one?
No, sir. In case of silent, this thing we don't have to close, sir.
Sorry,
Asymptomatic.
you have to close the ductus at all times because it
Okay.
causes infective endocarditis.
Okay, understood.
So that is the dictum.
Yes.
Ductus always should be closed. Isolated ductus should always be closed. Next, the timing. If in an asymptomatic patient, what age? What is the recommendation of the Indian Society of Pediatric Cardiologists and Surgeons?
Yes, sir.
Doctor.
So asymptomatic small. This
Jairaj sir
12 to
always
18
quotes that article.
yes, sir. 12 to 18 months in the small PDAs, small asymptomatic PDA.
Hmm.
And in case of large with failure, with say as early as 6 months. In case of
Okay.
moderate, we can yes, sir. In case of moderate VSD with no signs of failure, we can close at 1 year. If it is a failure, we can close it earlier.
In a large symptomatic PDA, you will close at any age.
Any-
In an asymptomatic PDA, you will close at between 18 to 2 years, 18 months to 2 years. And all ducti should be closed.
That's it. The usual teaching is that small baby with a failure which cannot be controlled by medicines is closed at any age, irrespective of 1 month, 2 months, 3 months, or something. A patient with a ductus with a left heart failure, if it can be controlled with anti-failure medicines, close at 6 months. If they're asymptomatic, then 18 months or 15 to 18. That's a classical thing. What is silent ductus? Yeah, I'm sure you're saying about the silent ductus, which they say doesn't need close. Silent ductus is only echocardiac finding. There's no murmur, there's no other sign. That's the one they said need not close. But any other ductus will produce a murmur. This is only echocardiographic finding. And then usually you answer that most of our surgeons will prefer a surgical closure because it's a minor procedure. And the cardiologist, depending on the age, you said less than 6 months, and if it is less than 1.5 centimeter, 15 millimeter, a device. And what are the devices used and on what occasions will you use each device? What are the devices you know for closing the ductus?
For less than 4 mm, we can use the coils, giant Turco coils.
Giant Turco coils. What are giant Turco coils?
It is made up of the diaphragm fibers which promote
Yes,
thrombosis.
stainless steel, yeah, with that. So usually they say less than 4 millimeter you can use
Then
giant Turco
coils.
coil. If it is maybe 8 millimeter, sometimes it's a multiple coils can be used.
Yes, sir.
What other device you know?
The amplifier duct occluder that we can use.
Yes, the amplifier piccolo duct occluder. Then there's some buttons, and then there's the Raskin umbrella, but that's not used now. The amplifier device is used. So what is your idea, whether you will do surgery or whether you send for this? In this hospital, what is the usual practice?
In this hospital, mostly they plan for the small, which is accessible for devices, they will go for device only. Sir. Only the failures not present, not manageable with the medications, that they are surgical, preferring surgical. Sir.
Correct.
Most of the
See,
So
there is
you-
another method of closure of ductus, and that was by wax clipping.
yes,
I did 2 wax clipping when I was in St. John's, and subsequently I never got another case for wax closure because the indications are similar to what the device closure was going to be done. So all those ducti which were small in size and this thing were closed by the devices, and we never get to do a wax closure.
Yes.
So as you rightly said, only large ducti, complicated ducti are referred for surgery nowadays.
Yeah, should say that surgical closure, wax closure, robotic closure, and the different types of cat closures you should know.
Anything else? You must also know the long term. Is this a curative surgery or a palliative surgery?
curative surgeries.
Yes. So this is more of one of the few cardiac surgeries which are curative. And generally you don't need to do anything else for the rest of their lives.
Yes,
Yeah.
yes,
So that is why all ducti should be closed before they develop pulmonary arterial hypertension. And then maybe follow up initially for a couple of years, and then they are left on their own. They can lead a perfectly normal life.
yes, sir.
Any other questions? There were supposed to be some few students from Chennai. Were they able to log in?
Yes, sir, they were logged in from MEAT, no, so they were logged in.
Yeah, because they are Richard students. He had requested. Okay. Any questions from anybody?
So in this age, maybe can we say pulse rate, sir? Because theoretically they are saying bounding pulse with wide pulse pressure. So can we say like pulse rate, or we have to mention only heart rate? So till what age we should say?
In a child, a small child, infant, 10-month-old child, whichever is easily felt. Heart rate is good enough.
Okay.
Because you can't really make out, the collapsing pulse or a bounding pulse
Yes.
in a small child. Okay.
Yes.
So that's okay. Those are small things, nobody's going to penalize you for those small little things. All right. Basically nowadays, most examiners don't even bother much about the physical examination. However, as a surgeon, you must know these are steps that you cannot miss. Okay, you have to As people say, you have to learn to sit, stand, walk, and then only run. So don't go on to cath and CT scan straight away and say, okay, I will do this, I will do that.
Yes, sir.
You have to know the history, you have to know the progression of the disease, you have to do a physical examination, and then go on for the investigations. Don't forget this sequence.
Yes, sir.
In the exam, it is very important that you go through as a sequence.
Okay.
Okay, thank you.
Thank you.
Thanks, sir.